Good evening. Good evening. Okay, it's so dark I can't see anybody. Yes. So, good evening. I'm Charlie Alexander. I'm a program officer and I direct the Action Collaborative on Clinician Wellbeing and Resilience. I would like to thank the ACGME for hosting us this evening, this beautiful evening. Glad everybody could make it. Some of our folks aren't going to be here in time, but they'll be here tomorrow for the public session. We're really excited about today. Um, the Action Collaborative on Clinician Wellbeing and Resilience, we launched it in January 2017, really with three key goals. The first is to raise visibility of challenges to clinician well-being, to talk openly about burnout, depression, moral injury, and suicide, to improve understanding of the challenges to clinician well-being and what the consequences are for clinicians, for patients, and for the healthcare system, and really to advance evidence-based multidisciplinary solutions that will improve patient care by caring for the caregiver. And to achieve these goals, we have a number of working groups. They've developed several discussion papers. We have a conceptual model of the factors affecting clinician well-being and resilience. We have our Clinician Wellbeing Knowledge Hub, and we have a number of convening activities to bring different stakeholders together to talk about pressing challenges for this issue, which is why we're here today. So, over the next couple of days, we're really devoted to exploring redesigning the clinical learning environment to improve clinician well-being. Tomorrow's meeting will include a number of presentations and discussions about identity formation, returning humanity to the healing professions, personal and courageous conversation. Tonight's event is dedicated to storytelling. We're going to hear from an interprofessional and intergenerational group about personal reflections on clinician well-being. The stories are complemented by our Expressions of Clinician Wellbeing art show, which is in the lobby. How many folks have seen it? How many folks liked it? Clap, because I can't see you. Okay. Beautiful. So for this show, we called on artists of all skills and abilities to reflect what clinician well-being looks, sounds, and feels like to them. And it's one of our avenues that we're using to break the culture of silence, to really talk about some of these issues openly and honestly. We're very pleased that the art show has been hosted or recreated by several organizations across the country, and it's been on the road for about a year now. So before I turn it over to our MC for the night, I want to thank the following people. I want to thank Tom Nasca, Tim Brigham, Liz Emery, and the full team at the ACGME. I want to thank the NAM team, and I want to thank the planning committee. If you all could stand, and we'll give you a well-deserved round of applause. Thank you. So now I'll turn us over to our MC for the night, Shelly Patel. Shelly is Associate Professor of Restorative Dentistry and Director of Clinical Simulation at the University of Texas School of Dentistry. Shelly? It is dark here.
Um, no one has ever called me an MC, so moving on up. Like Charlie said, my name is Shelly Patel. I'll go by Shelly. I do teach at the University of Texas School of Dentistry at Houston. And with the help of my students, my dean, and others, we have created a storytelling event at our institution, which tonight's session is modeled after. I remember as a little girl, my grandmother used to tell me, "Come sit next to me and I'll tell you a story." And I couldn't tell you who was happier, my grandmother, who was a master storyteller, or I, as a little girl, just ready to get lost in her stories. Interestingly, she was illiterate. She couldn't read or write, but she connected with us with her stories, and she passed that on to her all her grandkids. Um, Though my grandmother was very influential of who I have become over the years, she was not the one that inspired me to create this storytelling event. It was a student, a tired, and burnout second year dental student. He emailed me and asked me to meet with his class, give a pep talk, and sort of help him and his peers to keep going. I could have easily ignored his email. I mean, we do that a lot, right? So, but deep down, I knew that I had to do something. I knew that I could almost feel how he felt. I felt it as a student. I felt it as a clinician when I was in private practice. And I certainly feel it as an academician. In healthcare, regardless of our field, dentistry, medicine, optometry, pharmacy, nursing, we spend all of our time and effort learning, training, and practicing. That's our focus. And when we finish school or residencies and we go on to our practices, we continue to do the same. We keep going to perfect our skills, overcome the next challenge, jump the next hurdle, earn the next promotion, and until one day we realize that we're missing something. We feel alone, disengaged, isolated, unsatisfied, burnout, and depressed. So deep down, I didn't ignore my student's email because I felt his plea. And for once, I wanted to break the cycle, at least for one day, for one student. Now, there are several schools, medical schools, such as Columbia, Stanford, Baylor, and Temple University, which host similar narrative medicine events as part of their humanity curriculum. But no dental school has ever done that. There's a misconception that dentists really don't need to connect with their patients because their mouth is open anyway as we work on them, and they can't really talk back. So why bother? That's the old approach. We know that healthcare is moving toward a patient centered model where we encourage shared decision making and emphasize the patient experiences. But even with all that shift toward humanism in healthcare, the burnout rates are going up. They're not going down. So it begs the question, have we turned the humanism curricula into another acquired skill? Another process to optimize, another box to check. I don't know, perhaps. I don't know. And don't take me wrong, because I do believe in teaching humanism. And matter of fact, as my position as the clinical director of simulation, I teach it all the time, and it's such a pleasure to teach it to my dental students. My only point is then, why is it that burnout rates are going up? I think that we need to stop treating everything as a transaction and learn to reconnect with each other authentically. And that is where storytelling comes in. So going back to our storytelling event at UTSD, let me tell you a little bit about that process. We decided to host it after school, so sort of like this, with wine. You need wine when you tell stories. And food, because we were keeping students after school, you have to feed them. And it was open to all members of our dental community. We picked a name. We called it Behind This Smile, Stories in and Out of Dentistry. We designed a logo. We made announcements, recruited storytellers, students, staff, administrators, alumni, established rules and flow, and scheduled coaching sessions, and we booked a venue. As of right now, we have hosted 2 events, both at sold out capacity, over 120 attendees for each session. All the surveys and the video interviews from the audience and the storytellers have marked the event a success. It was a success because it brought the entire community together. During the event, there were no faculty, administrators, students, staff. There were just all the titles, all the barriers were gone. We all were human beings with stories and desire to listen and connect to each other, learn from each other, and help each other to heal. So, like I said, today's event is modeled after Behind This Smile. We have 5 amazing stories, each presented by our dynamic storytellers. These stories bring up deep rooted issues to light. Some might be uncomfortable to face, but they need to be heard. It may help us make stride toward addressing imbalances that have long been present. Storytellers, thank you for choosing this platform to tell us your story. I praise your courage. As I introduce you, you have the stage for 6 minutes, and we have a timekeeper. She's keeping time on me right now. Audience member, thank you for being here tonight. We appreciate your support. We ask you to please respect our storytellers as they're about to share very personal stories and thoughts with all of us. We will open the floor for questions, reflection, and comments at the end. So here we go with our first storyteller. Our first storyteller is Dr. Adina Arain. Dr. Arain received her doctorate of dental surgery 11 days ago. I had the privilege to be her teacher and her mentor as she experienced dental school. She will be reading a story entitled Blossoming in Adversity, written by one of her peers, Miss Afreen Ansari, who is a current third-year dental student at the University of Texas School of Dentistry at Houston. Dr. Arain.
Loud screams echoed throughout a small, 3-bedroom apartment. I instructed my sister to lock the door, knowing all too well that something devastating was happening. Just then, the doorknob rattled, and I learned my mother was beaten until she fell unconscious. There was blood everywhere, and she received staples to heal the scalp lacerations. The 3 of us were transferred to a women's center the same day. I moved to 3 different schools in 3 months and struggled with reading comprehension and paying attention. I had to work hard to teach myself and learned as much as I could in school to catch up to my peers. After several years, I made the decision to get married early, at 19. My role was, well, to do everything: attend school, clean the floor on my hands and knees, cook, wash piles of dishes, work, and pay the bills. My decision to pursue dental school was met with immediate resistance. After 5 years, we were divorced. The same year I started dental school. I cried every day for months. Dental school has been a constant for me. And for the first time ever, I felt in control of my life. I am blessed beyond recognition to be confined to these 4 walls every day. My decision to pursue oral and maxillofacial surgery recently solidified. And honestly, I wasn't even doing all that much the moment I made my decision. Just removing staples from a patient's wound.
Thank you, Adina. I think this quote says it all. You can recognize survivors of abuse by their courage. When silence is so very inviting, they step forward and share their truths so others know they aren't alone. I know that this is the case with Afreen. She recently broke her silence during our Behind the Smile event so that she can heal and become a support system for others. Mentioning healing, our next story is titled Pharmaceutical Healing by Mr. Kofi Ando. He's a PharmD student at Notre Dame of Maryland University School of Pharmacy. He will share a touching story of how clinician burnout has affected him on both personal and professional levels. Mr. Ando?
All right. Good evening. So, I didn't write a story like Adina, but I will talk about a personal experience that could be kind of like an open discussion. So, a little background on myself. My name is Kofi. I graduated from Howard University in 2017. I know I'm very old. Um, I was a 4-year full scholarship athlete to play basketball at Howard University. I played Division I basketball, and I know many of you like housing and healthcare. Um, so my freshman year, my mother was actually diagnosed with cancer, and the diagnosis at the time, I didn't know much about it. I didn't think much about it. Okay, she's sick, but she'll get better. Um, that was the first time I actually was introduced to healthcare, the other side, where we had to venture to different healthcare systems, travel around, and the mainstay of her healthcare. Her regimen was at Johns Hopkins University in Baltimore. We're from the DC area. So that was the first time I actually got to see the interaction between patients, clinicians, pharmacists, doctors, things of that nature. It kind of sparked my interest in healthcare, but at the same time, back then I was still an athlete full time. It wasn't until my senior year where my mother actually passed away due to her colon cancer that she had, where I really had to take a step back and reevaluate certain things in my life, reevaluate my priorities and what I wanted to get out of my life. I felt like I had the intellect. I was a chemistry major. Um, I had the intellect and athletic ability. Initially coming out of college, if you would have asked me what I would have done with my life, I would have been overseas playing basketball somewhere. Unfortunately, due to the events that I've withstood in my life with my family, um, I felt with the ability that I have, it would be good to go into pharmacy to try to make a difference, to go into oncology, drug therapeutics, to see if there's anything I can do to prevent a family from going through what me and my family have gone through. So, that's why I decided to choose pharmacy and stay a little closer to home. Um, with that said, you think from a patient's perspective, you see people in white coats. You see, the stature, the degrees. You see, the achievement that all of these people have. What we don't see is the trials and tribulations all of us go through on a day-to-day basis. So me being a pharmacy student at the moment, it's the first time I actually got to witness that. I got to witness being in a clinical environment and seeing pharmacists, seeing doctors who have their degrees not satisfied with their lives, not satisfied with helping people every day, which is what we have an obligation to do. So, I thought to myself, why is that the case? Why are we in a position where we can help people on a day-to-day basis, where we can be fulfilled and still not have that self-fulfillment? Why are we, why do we go through some of the things we go through on a day-to-day basis? And it could be attributed to, how our clinical environment is structured. I feel like we have put the patients first, and that's a great thing. The patients are always first, but I feel like at the same time we have forgotten about ourselves, the way we structure our practice environments, the way we go about jobs on a day-to-day basis, even in school. Like myself, it's a competitive environment. From day one, they're telling you about how competitive the market is, how you have to be on your toes at all times, how you have to be perfect, essentially. So, like it was alluded to earlier, I think it's about, transforming or going back to, okay, healthcare, it's not just about, being the best clinician, not just about getting a 4.0, not just about being the most esteemed professional, but, you know, actually thinking about why did we choose to be in the position that we're in. I feel like everybody in here maybe has a personal story about, you know, what got them to be in the position that they're in today. Unfortunately for me, it was the loss of my mother. So I hope that, with, the position I'm in, the intellect that I was blessed with, I'm able to make a difference for people in my future that, maybe those that did not have the same resources or or opportunities that I have. So, I'm sharing that with you all. I'm sure many of you do not know that, but it's also, hard for me. I don't really open up about it a lot. But I think we're here and we're all here with great spirits, willing to reshape and transform our clinician practice environment. And I think awareness is the first step. So I thank you all for being here. And I also thank you all for inviting me out. And yeah, it'll be a great few days. Thank you.
Thank you, Kofi. I'm sure your mom is very proud of you, watching you standing here and entertaining us. And hopefully, her spirit keeps you going. Okay. Our next storyteller is Dr. Michael Colston. He's the director of Defense Centers of Excellence for Psychological Health and Traumatic Brain Injury at the Department of Defense. Dr. Colstons, please.
I just want to start by saying I'm really jealous of Kofi. 4 years of Division I basketball, the option to play in Europe. I set new standards for ineptitude in my 4 years of college baseball. And there really wasn't an after story for me. Okay, I'm a psychiatrist. One of the things we do in supervision is we try and talk about other people. So as I was writing this, I started with a story that moved me about somebody else, and about a page in, I was like, oh, I got to start talking about myself. So this will make it easier for me. So as the NBA finals start this week, I thought I'd move my association pattern from tangential to just flat out loose by talking about Steph Curry and his relationship with his coach at Davidson, Bob McKillop. Which I think relates to the clinical learning environment and milieu in some manner. The short story is that Bob McKillop was a revered basketball coach who developed as a professional in the mold of other basketball coaches, win games, develop teams focused on defense and ball control, and mentor the players in the traditional top-down, peremptory, you will type fashion. And then came Steph Curry, a player who came in with a wave of players who essentially blew up the game of basketball, spreading the floor, shooting three-pointers from obscenely long ranges, and really turning basketball into a mash of analytics and improv. And the question for Bob McKillop, which we face as senior physicians, is who needs to change, the players or him? The answer that he found his happiness by meeting the players where they were, supporting their strengths. So for Steph Curry, that meant letting him shoot from wherever he wanted, being less directive, and being more collaborative and supportive in his role as a coach. The story ends well. Both Mr. McKillop and Steph Curry reached top echelons in their field. And when asked about one another in the press, there was a recent article in The Atlantic, most of the talk isn't about basketball. It's about their relationship. And the striking aspect of that relationship is equality, despite the difference in age and power structure. Bobby Knight would have had a seizure. So I found some of the same currents ran through my head as I did a late career child psychiatry fellowship right up the street in Streeterville in Lincoln Park at Northwestern. As a military physician, I had about a decade of practice under my belt. And I walked in, I'd been in attending, so I was ready to lead a treatment team, staff cases with the child attendings, and move out. Didn't quite work out that way, and I think that was for the better. Under the leadership of a number of strong program directors, all females, by the way, we're 85% male in the military, Northwestern had developed a real culture of egalitarianism and support in its clinical learning environment. So what did that mean for me, and how did I bristle? Of course, I wrote orders like all physicians do, but I wasn't in charge, even in regard to dispositions. Our clinic directors included psychologists and social workers, and sometimes they had valuable input even after my decision was made about a disposition. So disposition decisions changed. even after a case was staffed with an attending. That would have been frowned upon in the military. Our grand rounds and case conferences included all disciplines. As a physician, I really needed to be able to discuss psychosocial details that I really wasn't accustomed to talking about. And then there were the 360-degree evaluations. We don't have those in the military. Um, so our clinical learning environment developed really to foster interprofessional milieu with trainees and practitioners across a lot of disciplines having input on patient care structures and the nature of our training. And well-being was fostered by a sense of agency, but that meant everyone's agency. There was a culture where you define yourself less by your position and more by being a member of the team. So while technical competence was and always is a crucial aspect of professionalism, a culture of respect was equally valued. And what that meant for me and what I saw on the 360 evaluations was that decisiveness, a key aspect of officership, was less good in a team setting. So for me, civilian fellowship in a far different culture from where I was professionally raised, personally brought me joy and meaning and changed my outlook on leadership. Looking back, it was a wonderful 2 years of my life. It was wonderful living in Lincoln Park and being here with my kids. And I truly didn't appreciate the nature of the innovations that we're talking about in these groups. But they really started there, and they started because professionals valued it. So I'm a believer in the new program.
Thank you, sir. I don't know much about basketball, except that I'm from Houston and not a real big fan of Mr. Curry right now. So, our next speaker is going to talk about belongingness. Dr. Amy Hildreth is an associate professor and program director of general surgery residency at Wake Forest School of Medicine. And this notion of belongingness really resonates with me, so I'm really, really excited to hear her story. Amy?
Thank you so much. Thanks to everyone for being here. So this story begins in an operating room. And in this particular OR, I'm a third-year medical student. Patient Mr. S has sustained a thoracoabdominal stab wound, and he's in shock. He's been taken to the operating room emergently, and the surgeons with whom I'm scrubbed perform a laparotomy and a thoracotomy. They take out the spleen, they ligate an intercostal artery, and they repair the diaphragm. There are tense moments, but Mr. S survives the surgery. The whole time, I'm holding a retractor, and I'm thrilled to be there, but I'm not sure anyone notices me. And afterwards, the surgeon pulls me aside and says this life-changing thing. He says, "Whether you know it or not, you're a surgeon." And I'd never considered it before, but I knew immediately when he said it that he was right. And so over the next few months, I tried on all the other specialties for size, but nothing else seemed to fit. So I get braver, and I tell a few people of my plans. And in the surgeon's lounge, they look surprised and maybe a little amused. No one tells me I can't be a surgeon because that would be sexist, but plenty of people tell me I shouldn't. You're too nice, they say. Surgery will change you, and all the women I know in surgery are miserable. So I look around at the others, and they're in green scrubs, and I wonder if I will ever belong. I enter surgery residency against all advice, and as an intern, I'm scared, and I'm way too timid. I say the wrong thing or give the wrong answer. I'm constantly saying the wrong thing. Mostly my hands do the right thing, but sometimes they fail me as well. Once in a vascular case, when tying a knot at the end of a case, I throw an air knot, which is a knot that fails to cinch tight and approximate the tissue. And we remove the suture, but the surgeon is angry, and he says, 7 months into intern year and you still can't tie a damn knot. He keeps talking, but I can't hear the rest of the words. My eyes water and my ears are ringing. My eye protection glasses fog up, and I keep operating. hoping no one looks up from the patient to see me cry. Crying is weak. There's no crying in surgery. I learned how not to cry. Humans are social creatures, and we seek out community. We're more mentally and physically well when we feel we belong, and I was no different. As I trained, I looked around, and there weren't many others who looked like me. I was a woman, was training in the South, and I was a liberal. I was kind of a sensitive person, which goes sort of against the stereotypes, right? And all of these things seemed wrong. The people that I was around were mostly guys, and I just wanted to be one of the guys. They all seemed tough and like nothing could hurt them. At parties, they drank brown liquor and they smoked cigars. And I tried to develop a taste for scotch, and I smoked cigars until I wanted to vomit. And it didn't help. I wasn't one of them. But surgery itself was so much fun. And I honestly had wonderful mentors and made some of the best friends of my life. And I received excellent clinical training. And yet I never completely felt like I was part of the club. At the end of residency, the tradition was to roast the chief residents, as maybe it was in many of your programs as well. Everyone was given a T-shirt at the end of the roast. It was white with these large black block letters that you could read from a distance. My co-resident Kai was recently married and had previously had a vigorous dating career, and so he got a shirt that said "ex-player." My friend Steven, who was kind of gruff and serious, got a shirt that said, "This is my happy face." But my shirt read "token," which was a reference to the fact that I was the only female resident in the program for many of my years there. And in the moment, I suppose we all thought the shirts, mine included, were funny. And in the pictures, when I look back at them, I'm laughing along with everyone else. But what I remember is that feeling that the shirt proved that I was different and perhaps less than the others graduating that day. So I left my training program and I joined a practice where I was the only female trauma surgeon. In the beginning, I was mistaken for a student or a resident or nurse or the person who brings the ice water to the rooms. I kept my head down, and at first I struggled. I was terrified I would do the wrong thing or hurt someone, let down my partners. I was often defensive, and I was mostly on the lookout for proof that I didn't belong there. But despite my apprehension, things mostly went well. I had the occasional complication, but others did too. I felt more comfortable in my own skin, and I began to tell my stories. I let people in. I listened to who my colleagues were rather than who they seemed to be. And I learned that I was safe to disagree even with those who had power over me. I learned how to let myself express sadness and anger even at work in healthy ways. And eventually, I stopped trying to be the things I thought a surgeon should be, and I began to be myself. I stopped working to fit in. And at a time I can't precisely pinpoint, I looked around and realized that I belonged. The author and social scientist Brené Brown has written about this concept, and she says, fitting in is about assessing a situation and becoming who you need to be accepted. Belonging, on the other hand, doesn't require us to change who we are. It requires us to be who we are. And so the story ends like it begins. An OR, 2:30 a.m. I'm outside the door looking in, and the residents are ready, and they make the incision. I wash my hands at the sink, and I enter, and I belong here. I realize that this sense of belonging comes from a place of privilege. When I walk into the OR, it's my OR and my patient, my instruments, my residents, and even my music on the radio. It's easy for me to feel safe in that space to be my authentic self, which is why I think it's vitally important for those of us who are in positions of power to create such a space for those around us. As I supervise the operation, I think about the residency program, which I now direct. There are 43 residents. Half of them are female. 20% are from groups underrepresented in medicine, and they come from different geographic areas and backgrounds. It's a diverse group, and most of the time, they seem happy. But still, as I look at them, I think of my younger self, and I wonder if they feel safe and if we as faculty have created a space where they can express themselves authentically and truly belong. Thank you for your attention.
Thank you, Amy. That was such a beautiful story. I thank you for sharing it with us. Many of us, regardless of our cultural or educational background, can feel lonely, disengaged, and isolated. Perhaps storytelling can help us reconnect, normalize imperfections, and reduce burnout and isolation. Thank you all for your attention. I will ask our storytellers to come up on stage. At this point, the floor is open for questions, comments, and reflection.
Thank you all. That was wonderful. First, I'd like to say that the best relationship, almost the best that I have with a medical professional, is with my dentist.
Somebody taught them well.
Yeah, he's a great guy. Amy, your story particularly resonated with me because my previous career was as an engineer, and I come to this through losing my husband to lung cancer. And I was in the aerospace industry, and typically it was me and 40 guys. So I want you to thank you for sharing that. And I know there's the hashtag, I look like an engineer, hashtag, I look like a surgeon on social media, on Twitter. So that comes out there. And I agree with you. You know, it's really hard to just be yourself and accept that you're really not one of the guys, that you're different. And so I just want to say that it's the same in all different fields. It's not just being a woman here, it's being someone who doesn't look like the tradition and the mold. So thank you.
Thank you so much for that comment. And I think one of the important things I realized along the way is that not even all of the guys are one of the guys in the sense that I described. And so
Hi. Thank you, all of you, for sharing your stories. That was just beautiful and touching. I'll just choose one question for Michael Colton. To what extent were you able to carry that back, all that you experienced here, back to the DoD?
Well, I think one thing, I just was an attending down. I see children at Fort Belvoir, which is just down the river from the Pentagon, and my third-year resident said, "Hey, Mike, you're pretty chill," which made me feel good. That was, obviously our culture has changed, and we're struggling with a lot of things in the military, not just in military medicine. I testified to Congress twice in the last month about really the scourge of suicide, stress in our ranks, and what we can do about it. And I think it starts with being good to one another. There was a way that we met each other's affiliative needs, both in my medical training and in other jobs that I had in the military. I was an engineer before I was a doc. Closer to Full Metal Jacket, which, there was a sense of teamwork, but there wasn't a sense of humane leadership always. And I think that's really important, no matter where you are, is that you need to be humane. And I see our culture shifting to the better in that regard. Now, outcomes, outcomes are brutal. They're brutal everywhere. They're brutal in surgery. If you're a cardiothoracic surgeon with bad outcomes, patients don't come see you. I think in regard to the military right now, there's a lot of focus on what's going wrong, especially kind of in the social milieu, transgender folks, our problem with suicide, things along those lines. So I think in medicine, just as with the military in general, we need to focus on being more humane.
Thank you guys so much for all of your storytelling reflections. My questions are particularly for Kofi and Adina. As an aspiring medical student, it's really great hearing like your very candid reflections about your whole process, and I know self-care is such a buzzword that's thrown around a lot these days. For me, that's watching Game of Thrones, or was anyway. And I'm wondering, how did you guys practice self-care for yourselves during your journey? And do you think that humanities in medicine or humanities in dentistry is an appropriate way to kind of alleviate the stress during the journey?
So that's a great question. I think any medical profession school is getting tougher and tougher every year, not just to get in, but then to stay in. And it can get really, really overwhelming. I think the most important thing when it comes to self-care is to stop when you know you need a break and give yourself that break, even if it means it's the night before an exam and you're behind, because stopping for an hour and resting and coming back and looking at your notes is going to be way more productive than staying up and trying to focus that 1 hour. I learned that the hard way. I pulled one all-nighter, and I probably did the worst on that exam because I did not practice self-care. So I think it's very important to do that in school, because there's always going to be something. I mean, you might say, "Oh, it's just school. Like I need to get those grades now." But when you're done and you're practicing, there's always going to be something. It's just that's one more patient, or I need to pay this one more bill or do this one more thing, and it's a habit. So you need to form those good habits in school, and then carry those on through your career. So yeah, if that means watching Game of Thrones, do it. I mean, do whatever it takes, but take care of yourself, because if you don't take care of yourself, no one else will.
I also don't watch Game of Thrones. So for the people in here who don't know what's going on half of the time, that's me. Pertaining to self-care, in school, I'm one of the people who I would say I don't devote as much time as some of my peers do to pharmacy in terms of just personal study time. We live in a day and age where we can get on our phones and see how great our peers are and constantly compare ourselves to our peers and people who are in position that want to be where we are, or I'm not good enough. And I try to drown out that noise, just by focusing on what got me to the position I'm in. I think sometimes we complain about what we have on our plates, but ultimately we were also in a position that we prayed for, we hoped for the obligation that we have today. So one of the things that I did, or I do currently, is I don't overstep my boundaries in terms of my personal and professional life. I try not to let my professional life supersede my personal needs. Um, if that means I have an exam on Monday and I've been going hard 40 hours a week, the entire week, I still give myself that needed break. I still go out with my friends. I still do certain things, and it's to the point where some of my classmates are like, "How did you get an A on that test? I just saw you were in DC, running around." I'm like, I don't know, but I think if taking care of myself personally, I think that's what helps me do well in school. Because ultimately, I could study all day and forget about my well-being personally, and it wouldn't do much justice for myself, and that's how we burn out, as we call it. So that's my thing. I try to partition my life as best as possible, and it's been pretty well for myself so far. I hope to continue it. I know, as I graduate, things won't be that easy, but I try to balance my personal work and work and personal life as best as I can.
Thank you very much for all your very touching stories. I'm just curious if any of you has any guess on why, despite the fact that hours were limited by the ACGME and it was a great help, why are burnout rates going up rather than going down?
I think you can look at kind of any question like that. One is, are we? By the way, what do you mean by that? Does that mean get your? Okay, thank you. I think you can look at any social problem, and one thing I think it says is we're measuring it better. I was always struck by a picture of in California, the mental retardation diagnoses going down and the autism diagnoses going up. It was a recognition of the problem, and that speaks to in my view progress being made. On the other hand, I think of what's different now than, say when I was training. And it seems like there's more isolation, more time in front of a screen. And I have young kids, and it strikes me what a struggle it is to keep them away from that screen. And so much that we do now is on the screen. So much that we do in medicine is on the screen. You walk around the ward with an iPad or something along those lines to enter notes and dictate things and things along those lines. So I'm not sure, but I think part of it is a good news story.
Yeah. I was just going to say I think the answer is that it's not about the hours. I mean, I think we're perhaps measuring the wrong thing. I mean, sure, I trained sort of bridging the era of no work hour restrictions to the era of work hour restrictions, and all of that happened during my training. And I'm not arguing that we should go back to working 100+ hour weeks. That's obviously not healthy, and we know a whole lot more about sleep now than we did, and about its effects on our long-term well-being, including our health and the health of our patients. But I don't think that that burnout and hours are directly correlated. I mean, for instance, I'm here. I was on call Memorial Day weekend, either on call or backup call. I finished my last case at 6:45 this morning, and I haven't slept a whole heck of a lot. But I would say that on the grand scheme of things, this has been a pretty meaningful 36 hours for me. I had a partner who fell off of his horse and got some rib fractures and had to have a chest tube, and so I got to kind of have an odd experience, which is to treat your partner for the first time in your life. But it was also nice because I was able to do something helpful. And then on the heels of that, come here and do something else that I find very meaningful. And so this is probably not, in the grand scheme of things, a high burnout time for me, despite the fact that I've worked a lot of hours in the last 96 or so. So I think it's just not. I do think that the hours are important, but I think we shouldn't overstate their significance with relation to burnout.
I know I'm just a new grad, but I think just from where I sit, in medicine in general, I think it's like Dr. Hildreth said. I loved her talk because it addressed a very important point, and Dr. Patel and I were talking about this, that there's obviously something wrong with the way we're addressing burnout if the rates are going up. I don't know if it's the curriculum or what it is, but I still think there's a fear of expressing our emotions. And I think that's what maybe might heal and might help decrease the hours. Like you said, it's not really the amount of hours, but maybe it's just us addressing the issues and kind of expressing how we feel. Because I think that does help to heal. That's why I think this event is so awesome, that we're doing this and people get to talk about their experiences. I think there's it's considered weak in medicine, or like I know I might not feel comfortable going to faculty or going to a supervisor or somebody in a higher position and telling them I feel weak or I feel burnt out. It's like this, we don't even want to talk about it because it makes us look weak, and I think that's the problem.
Thank you, all of you, for these wonderful stories. I think they're incredibly moving to hear. And I'm just going to sort of throw out the big question, which is how, and we're struggling with this so much, how do we figure out how to take care of ourselves and to take care of our patients at the same time? So it's a little bit more challenging for those of you in school now because you're protected. But what happens when you get out there and we have to take care of the patients and we want to take care of ourselves? So I'd love to hear your thoughts on that.
So, we kind of have a mantra in the military, and just absent, the time issue, it's sleep, exercise, nutrition, and very little alcohol. I mean, those are, I think. Because, as you obviously, I find as I age, like even like a third of a drink, affects my sleep architecture. But, it's, I always find it's a matter of time. It's a matter of what are you going to prioritize and what are you going to devote time to. I'd love to have the 3 hours a day that I had to exercise in my 20s and 30s. I have 3 kids with a 4th on the way. I know I'm old; it looks bad, but but it's I think it's a matter of priorities. But I think the formula is there. It's just a matter of finding how it works, on an individual basis.
I think clinicians should partner with their patients. I think that's a real relationship that can bring joy to both sides. And I think the clinician really sharing part of their personal and their lives with their patients. And I've been very fortunate in that I've kind of picked clinicians that I've been able to do that with and have built some really good relationships, not just with my dentist, but for example, my orthopedic surgeon, I've been through 3 rounds of surgery with him, and his office staff signed up to walk in the lung cancer walk that I'm supporting on Sunday. So I think that's part of it, because from my standpoint, both the patient and the clinician are the only parties, stakeholders in healthcare that truly have aligned interests. And we don't do enough of that, and I don't think the clinicians bring the patients in and bring the patients to be equal partners at the table enough. And I think if that happened, then that would actually help.
I like to add something to that. I remember when I was training, they used to tell us every time you walk into an operatory to treat a patient, just know that that patient can sue you. And that was the mentality that they taught us in dental school. And so you already are isolated, and you're defensive. You walk in there and you know that whatever you say may be used against you in a court of law. And that is completely wrong. I believe what you said, that you have to create bonds with your patients, regardless of who they are and what they need. They may need it, in our case, they may need just a simple cleaning or a whole full mouth restoration. Get to know them before you touch them. Get to know them before you inject them. Get to know them before you treat them. And it is a privilege to treat another human being. It shouldn't be a fear like we were taught.
Thank you all for your time. Apologies for my voice. I'm recovering from a cough. So Dr. Hildreth, I really appreciated your story. And I was curious about the balance between top-down leadership and creating a safe space and a sense of belonging, and then what happens when leadership leaves the room and it's just the residents, whether it's, making the shirts that you talked about in your story, or things that might happen after hours and after work hours among colleagues. How can you balance the importance of top-down leadership in creating a safe space, as well as making sure that the collegial environment also exhibits that?
That's a great question, and a tough one, because as those of you who are in positions of leadership, you know that as soon as you get that position of leadership, that all of a sudden your perspective changes and you have very little knowledge of what actually goes on a day-to-day basis with the people that you're leading. The minute that I wasn't a resident anymore, then I was the last to hear all of the residency dirt. So yeah, it's very difficult. I do think as a leader, it's important to set an example. I think one of the reasons why the culture is what it is, where I am currently, is because of the leadership of our chair, which and the way that he has intentionally recruited faculty who have sort of a common mindset with regard to the way that the department should function and run. And I think that is sort of carried into how we select our residents. I know that I select specifically for attributes in residents, as far as you can tell in an interview, attributes of residents who are going to be team players. I try to create a diverse team, because I think part of the problem with the team that I was on as a resident is not that they gave me a shirt like that's a token because they were mean people, but because they just had no idea that would be offensive. It just wasn't, like my boss always says, the fish can't see water, right? So they had no idea that what they were doing would be in any way offensive to me. And so I think you have to create diverse teams so that people, function in a way that's respectful. And if when people don't, then there is a are different members of the team who can say, hey, that's not the way we do that here. But yeah, you're right. It's and I think it's also important for leaders to spend time in the trenches, so to speak, too, which is why I really love my job as an acute care surgeon, because it means I'm in the hospital at 2 a.m. a lot. And when residents are giddy at 2 a.m. and they've had 8 cups of coffee, then they might actually tell you what's really going on. So I think it speaks to the importance of actually being there as a leader to make sure that you have as much sense as you can of what's going on.
This question's for Kofi and Michael. I'm over here. One of the themes that's come out from the Action Collaborative is that healthcare is a team sport. And both of you guys are on different kinds of teams, the military and athletics. And I wonder what we can learn from military teams and from athletic teams that we can apply to healthcare.
I can go first. So coming out of undergrad, being an athlete for the majority of my career, I actually feel that it has fueled my career in healthcare and has given me a different set of I guess motivational traits. And I say that because with being a part of a team or an efficient team, you have accountability. So accountability in the sense that we are comfortable enough to tell our colleagues, our coworkers, what they can do better without taking offense, without making it feel like you're trying to comfort their position, without making it feel like you're chopping them down. And I think with being a part of a team the majority of my life, it has humbled me to the point where I'm able to take, constructive criticism and take a step back and look in the mirror. Okay, how can I do things better? I think that open dialogue in healthcare, it will achieve the same results. I don't think we have that same open dialogue. I think a lot of the conversation is behind each other's backs. Honestly, whether that's from a student on rotations talking about a preceptor, whether that's from being a resident frustrated with your hours or the workload that you have, being able to converse and have an open conversation and hold each other accountable for what needs to be done, what can be done to better our clinician environment. I think that is something that would carry over from being a part of a team to healthcare. I'm not sure about what
Well,
Mike
I
has
think
to
that's a
say.
great point in regard to accountability because, obviously that's a recurring theme in the military. And a lot of folks don't know. They think that, like, the person with the most power is someone who has, a lot of stripes or a star or something along those lines. And actually, the person who's keeping other people accountable the most in a military organization is the sergeant major, the guy who's like right smack dab in the middle. He's the most senior enlisted person, but he's junior to the 21-year-old person right out of college. And he's a person who can speak his mind. And we need someone kind of in the middle of the organization, middle managers to speak their minds. I mean, I think that matters. I think it matters every bit as much as, the salutary aspects of measuring everything, which of course we do now. I also think, obviously culture. So, I think folks may not know this, but, in the military, we were really the first folks in America to, address racism holistically in our organization. And, I think we got on top of that problem a lot earlier than other organizations. And it's really because we demanded it. And we really, if somebody heard about something that was said behind someone's back or something along those lines, there was an accountability in that regard. So, two things I think, both relate to accountability, but I think empowering middle managers matters.
May I speak? Hi. I'm a psychotherapist. When I was in graduate school, they ran us through the ringer as far as our own self-awareness, how we might hurt our patients, what our predispositions were for falling into our own mental health issues. And I'm really hoping that that's happening for people preparing to work on people physically. I know that you're probably learning how to recognize signs and symptoms in your patients, but are they teaching you about yourself and what your own predilection might be? Either you're going to run towards anxiety or depression, generally speaking, under lots of stress for a long time. The neurotransmitter system will just wear down. And so burnout, compassion fatigue, mild anxiety or depression, whatever you want to call it, I'm hoping that they're teaching you how to recognize signs and symptoms in yourself and what your tendencies might be. Is that happening?
We should have the recent grads. Yeah.
So I think they are teaching us, I think, surface, being able to, preparing us that this will happen. It's inevitable. You do have to address it and you have to take care of yourself. But I do think that's a very interesting point. Like, if we're learning about the actual biological processes that occur in patients with certain conditions, we should be learning about what's happening within us as we're going through anxiety and burnout and depression and whatever we might face in the future. So I think that's an excellent point. I don't think they're teaching it, well, at least not at our school. They're not teaching it at that level, but that's something I never thought about. I mean, we should be asking those questions as students, and asking to learn about the things that will affect us just as much as we ask about the things that affect our patients. Because if we're not healthy, how can we make sure our patients are? So that's very good.
I believe, well, at our program at Notre Dame, teaching, kind of like Adina said, it's only but so much you could do in a professional setting without knowing somebody personally. So you can recognize signs and symptoms in somebody, but it's similar to somebody's mom. You'll always know if there's something wrong with your son or daughter before a clinician is able to say the same. But we have been raising awareness, and I think that's the first step. At our program, I've had the privilege to be a part of piloting what they call the wellness initiative at our school, and it actually was in part motivated by our meeting that we had last year, the National Academy of Medicine in DC of last May. And I thought to myself, what can I do as a student to address some of these things that I see amongst my peers? So went to administration, and in talking with a few of the faculty and the dean, they thought it would be good for us students to lead a wellness initiative, and that we brainstorm ideas as students that we can implement on a daily basis in our learning environments that may appease to somebody who is going through mental toughness with our curriculum and things like that. One of the first things we did was implement, maybe a 10-minute break between our classes. Instead of an hour straight, we have a 10-minute break. And during that 10-minute break, we, provide snacks, or we meditate, which is great. Sometimes I fall asleep myself, but different things like that. We're brainstorming throughout the year. And I thank the National Academy of Medicine because, that was the first time I actually thought about it and sat down and got to talk amongst like-minded people. What can I do to impact my environment? So awareness is definitely being raised. In terms of teaching, I think that can be a point where we can improve. Teaching us, we study patients all the time, but how can we see in ourselves when we're struggling? Because a lot of times we put ourselves on the back burner. So I think teaching is definitely a point of improvement for us.
We have similar programs at UT. However, and students participate, some don't, most don't because of time, they're limited. And I think a lot of us as educators have to take that upon ourselves. I have no problem discussing my failures to my students. I'm very open about all the mistakes I have made, and I incorporate into my lectures, both life and professionally and personally, not just professionally. And I feel like when I open myself to them, then they will open themselves to me. And that, this behind the smile was a true evidence of that, where people came and talked about so many topics, so many stories, personal stories that even I was uncomfortable. And I felt for that. So I think as educators, we need to come down and tell our students that we're human. We made mistakes, learn from it, so you can be better than me. And just final thoughts. As you can see, there's a very diverse group of people sitting in front of you. Now that the lights are on, I can actually see you all. There's a great diverse group that are sitting in front of us, and I think this is the beginning of all the great changes that healthcare is going to see over the next few years. I thank you all for being here. Thank you for supporting our storytellers. It truly has been my honor to work with the Academy and to be in your presence tonight. Thank you very much for being here.
I want to give a thank you to Shelly, Kofi, Adina, Amy, and Michael. Unfortunately, our colleague Beverly Malone could not be with us today. She's on her way from O'Hare. We're not sure when she'll make it. But tomorrow, if you will agree, I will ask her to share her story tomorrow. So thank you to all of you for being with us today. I hope we can take a page out of our storytellers' books tomorrow and really lead with authentic and courageous conversation. And so we have the room until 8 o'clock, and we'll see you tomorrow if you're joining us. Thank you.